So I'll continue along and give a very quick overview of autism spectrum disorders, since I imagine that some of you know everything I'm going to say, and some of this will be new to other people, and I'd like to use it to more or less set the stage for our discussions. So, and Scott has already mentioned this, but the prevalence of autism now is said to be 1 in 150, which really means on a practical level that practitioners are likely to have at least 10 children in their practice with autism spectrum disorder. And as opposed, as Scott said, to what they know about cancer, many practitioners know a lot less about something that's more prevalent, which are these developmental disorders in general and autism in specific. So the first issue, speaking as a clinician, is that what we do know about treatment is early intensive treatment has the best chance right now of making a big effect in terms of outcome. What do I mean by early detection? I mean in the first 3 years of life, and many programs will not even take a child for this kind of intensive treatment if they're over 5. But here are just the facts, that parents almost always have some alert that something is going on developmentally by about 18 months. Even so, sometimes it's put off by primary care physicians who would say something like, well, he's a boy, so he's going to maybe develop speech later. And I think this is changing now, but the fact is that the first evaluation often comes at 4 years, and the first diagnosis actually comes around 5 years, which is when the program stopped taking you. So the first mission that we need to be aware of is trying to identify this early, and that is a very big charge, and we can talk some about that in the discussion today. So as Scott alluded to, there are pervasive developmental disorders, and this is the same thing as saying autism spectrum disorder. And Scott talked a lot about Rett's. There's another one, child disintegrative disorder, that are listed under the autism spectrum, but may not be real. They may more be syndromes with autistic features than really autism itself. And the 3 disorders that are recognized as autism spectrum disorder is autism, Asperger's disorder, and pervasive developmental disorder, NOS, which I'll review quickly. What we're stuck with as clinicians is needing to make this diagnosis only by looking at behaviors. For most of our medical practice, we have tests to confirm behavioral diagnoses, but for autism, we don't have any reliable tests except, as Scott mentioned, for the 5% or so of children who actually you do the chromosomes and you can find out something about what's been causing the disorder. But these are, so we're kind of left with a diagnostic formulation or criteria that's called the DSM-4, which is the Diagnostic and Statistical Manual of the American Psychiatric Association. And this is what's listed for the criteria for autism, and Scott spelled this out. There's a social piece, a communication piece, and restrictive repetitive behavior piece. And formally, to make this, and you can see what the items are, in order to make this diagnosis, you need 2 of the social piece, and at least 1 communication and 1 restrictive repetitive behavior piece before you can make a definitive diagnosis of autism. Now you can see here there might be some problems, and we encounter them all the time. So look at things like eye contact. So children with autism have a problem with eye contact, but exactly how do you operationalize that into a diagnosis? So does that mean no eye contact? 80% no eye contact only with parents, eye contact in certain situations where children are comfortable. So we don't have good ways of actually defining these things, and that's where a lot of the behavioral research is going. And the second issue, when we're talking about younger kids, many of these criteria, if you read through them, they don't apply to children 3 and under, who are the children we really want to be diagnosing. So holding a good conversation is not something that is developmentally appropriate, and almost none of these restrictive repetitive behaviors have even come up developmentally before children are much older. So one area we're looking at, and you saw that Wendy Stone is going to be a speaker at one of these forums that she's particularly interested in, is how do we identify the younger kids? Well, one thing is in the criteria that before the age of 3, you had to have some sign of either social problems, language, or communication, and symbolic play, which might be picking up a block and using it as a telephone, or using your imagination in play. And then, as Scott alluded to, there are a lot of coexisting conditions along with autism. So 50 to 75% are said to have mental retardation. Now, this is a little tricky because as we get to know more and more about this, the number of children who are higher functioning seems to be going up and up. But even so, the best predictor of how someone's going to do is not the autism itself. It's often their developmental level or their IQ level. And 5 to 10% have the kind of rare disorders that Scott was talking about, where you can actually identify the disorder. About up to 30% have epilepsy. And we don't even know a lot of other conditions that often go along with it, like ADHD, depression, anxiety, because some of those, by the rules of the manual, some of those are not supposed to be diagnosed if you have autism, and they're just kind of assumed to be under autism. But plenty of kids do well, say who have the ADHD symptoms, plenty of them do well on the same treatments as children who are typically developing who just have ADHD. All right, so this is Asperger's disorder. And for the criteria for Asperger's disorder, you have to have the social impairments or occupational impairments, and you have to have some restrictive repetitive interests or behavior. I have several kids with Asperger's or teenagers with Asperger's disorder who know absolutely everything about the weather. Everything. You know, they're scholars on the weather. And they're very interested in seeking out social engagement, actually. But their version of how to seek out social engagement is to tell someone what you're excited about, which is the weather. And what they don't pick up on is social cues to know that when you're talking about the weather for 15 minutes and you see, first of all, your friend's eyes are wandering everywhere and then he wants to bolt out of the room, they don't pick up that kind of social cue. They generally don't have any delay in the communication aspect, although they can't talk like little professors, for instance. And they don't have any cognitive delays, so they have average IQs. And they have a lot of curiosity about the environment, which some children with autism don't have. Then we get into the even stickier category, which is called Pervasive Developmental Disorder, NOS. And what this does, it allows you to diagnose autism where you think an autism spectrum disorder is still the best explanation for what's going on, but they don't quite meet criterion. It's very varied how people use this. So in little kids, like I was showing, they don't meet all the criteria. So even though you think they're going to have autism diagnosis in the future, you give them a PDD-NOS category classification because they don't yet have the restricted repetitive interests. It's too early to see them. And in general, social skills in these kids are somewhat less impaired, and intellectual deficits are less common. So one take-home point that I want to make is you can't just diagnose autism or autism spectrum disorder. It's never isolated. And Scott alluded to some of that. But if you want to make a treatment plan for someone with autism spectrum disorder of any kind, you need to know a lot more. So sometimes parents think they're coming in for an evaluation for autism, but what makes it so complicated is that you really have to know what's going on in several other areas than just these autism criteria. So this is just kind of a baseline of what you want to know. You want to have diagnosed or evaluated for autism, but you also want to know what the developmental level of the child is. In older children, do they qualify for the diagnosis of cognitive adaptive disorder or mental retardation? You want to know where their language is. Do they have any language? And then you want to know things for predicting what kind of treatment you want to put them into, like what is their eye contact like? Can they make it? Can they mimic things that they see? Are they using gestures? Can they point to things that they want, which is an early communication? So essentially, an evaluation is not just figuring out if someone has autism, but it's trying to figure out what are all the factors impacting on that child that have some value in determining what their course of treatment would be more effective. So now Scott has talked a lot about these things. The most common kind of autism is 4-to-1 boys and girls. And I'll flip around what Scott says, that about 60% of monozygotic twins from the same genetics, have autism. But what that means is, to me, is 40% don't. And isn't that astounding? They have the same genetics, but they don't actually have the disorder. Well, if you look at kind of, do they have some autism characteristics in the sibling? Well, it may be up to 92%, but it's the same question. Isn't it remarkable that 8% of children with the same genetics don't have any signs of autism at all? And then siblings are much more likely too. So I want to talk just a little bit about treatment. And so this is old breaking information, but because it was last week that I did this. But you can see just these two words, and you're a parent, and you've just received this diagnosis, so you think, well, I'm going to really do some research on this. And you find out that there are over 500,000 citations, and do you think Google puts them in the order of scientific evidence? So if you're a parent, you're in a really tough spot to try to sort all of this out. And it puts all of us in a tough spot to learn enough about what parents are seeing on the citations that they get from the internet to try to give them good advice. Again, Scott mentioned this, and I'm not going to go into it in detail, but what you really want to know in any treatment is, well, how much evidence is there for it? So starting down at the bottom of this pyramid, animal research and test tube research has very little reliability on predicting what's going to happen with children. And many of the things that you'll read on the internet or we hear about are on the level of someone's idea that it'll work, or editorials about it, or someone's opinion. So this is the Huffington Post level of evidence. And then you might have a case report. Well, I tried something and it worked, but that's not really enough to suggest that it's going to generalize. But then what you might do is a case series where you say, well, I tried this on 20 kids and it worked. But you still have a lot of doubts about, how does that generalize? Who were the kids? What were the conditions, et cetera? So then we start getting into about the first level that we consider fair evidence, which is you have a group where you did something and a group where you didn't do something. And then you have a cohort study where this would be like you're going to take a group of infants and you're going to divide them up into parents smoke and not smoke, and then see who is susceptible to lung disease. And then you have cohort studies, and then the studies that we accept the most are called randomized controlled double-blind studies, where you enter the kids into the study just randomly. You don't select groups, and you have a controlled group, and the investigator and anybody else doesn't know which group their kids are in until the end. And so that's getting to be a good study. Then a randomized control is here, and then at the top you pick an expert group to go through and construct what they think would count for real evidence, and then they review all of the studies that have been done and tell you what can we conclude from the best done studies. So the issue here is basically that, and I think everybody would agree who disagrees on almost anything, that if we had this kind of evidence up here and it cured autism, we wouldn't be looking for all of this other stuff. The problem is that there's very little evidence at this level about most things that have to do with the clinical treatment of autism. So we're kind of forced to kind of work down this and then make some good decisions about what could be effective without really knowing, without having the evidence. So I'm going to just briefly mention, these are the treatments, your array of treatments. And and what I urge families is to don't put all your money into one silo, no matter which one it is. Don't pick a treatment and exclude everything else that's a possibility. So their treatment for the core deficits, which are social and communication, and restrictive repetitive interest, educational, behavioral, medical, complementary alternative, and family support. So these are kind of essential things that most everybody with autism would be benefited by, which is some training in social skills for the social deficit, intensive language communication, restrictive repetitive interests and behaviors. About 10 years ago, there was a very good study on what we know about education. And these are just some of the points, but it's basically greater than 20 hours a week seems to be a magic formula for the intensity that needs to really make changes, and small classes and parents being involved, etc. There are a huge number of behavioral treatments. Anything from very, very strict behavioral treatments, like what you hear about as the Low-Voss method, over to naturalistic treatments that take place in the kids' environment in everyday life. And not only are these array of choices found, but a lot of programs will just pick what they consider the best features of all of these things and try to make them into a program that fits an individual. Medical concerns, well, the first one is obviously well child care and your primary care. And this is one thing I hope Alison Golnick will talk about a lot is, what do you do in a situation where you're responsible for taking care of families with children with autism and their siblings? Seizure disorders, tic disorders, ADHD, affective disorders, these are all medical concerns. There's been a lot of interest in kind of looking at behaviors and how they're influenced by medical conditions. So the first thing I always think of is if someone comes in with a sudden change of behavior, I think first, well, could this really be a medical problem that they can't talk about or identify because of their language deficits or cognitive deficits? So I always think about these things, and pain and dental, sleep can cause a lot of disorders in a lot of kids, a lot of problems, and a lot of kids with autism have sleep problems. So I always think medical. Then I'm not going to talk about this in any detail, but basically there is no medication that cures autism. There's no medication that takes all the symptoms away while you're taking it, but there are medications that if you're targeting things like aggression, hyperactivity, mood and affect, social withdrawal, anxiety, depression, and sleep that can all be very helpful. There are a lot of complementary and alternative treatments that have been talked about. Nutritional supplements, dietary restrictions, things that may have impact on immunology, non-biological treatments like sensory integration, off-label use of medications, and there's anything from evidence that these things don't work to no evidence at all to be able to make a decision one way or another. And I'm sure some of these things will come up in the discussion. And finally, I just want to say, when you ask parents, in my experience, for what they really want. If they had a wish list of 5 things, what would they want for their child? And number 1 is, well, I'd like him not to have autism. And we can't do that right now. But number 2 is usually, I need some support. I don't know where to turn. I go to 6 different places. Nothing is coordinated. The care isn't coordinated. The school's not talking to the therapist, who's not talking to the physician, who's not talking to the OT and PT. So what we really need, and again, I hope Allison Golnick will talk about this, is the concept of a medical home for children with autism, where basically someone takes responsibility for partnering with the parent to develop a system that actually works for them, and where they have more or less one-stop shopping with someone who has kind of the expertise to know what the options are and help parents go through this maze, but also listen to the parents and work with the parents around optimal care, which only the parents know best. So I'll stop there, and I know I've run a little over time, but I wanted to give more or less the spectrum of things that might come up in the discussion and that we think about in the treatment and care of kids with autism. Thanks.